Good morning, everybody. Thank you so much for coming. I wanted to just start off by saying that I hope this is not a bait and switch. There's a little difference between this lecture and what may be in the program. When Dan asked me to lecture on the latest and the greatest, I said yes about 9 or 10 months ago, and that was a very general topic until I got all the way down to the last couple of months, and I said, you know, that's a little general, and I wanted to narrow it down so there were a number of things that I could choose from, and this topic kept coming up in my practice. So I wanted to bring something to you guys today that hopefully will be helpful. I don't know, as a disclaimer, whether or not this is really cutting edge. A lot of the things that I'm going to talk about are review of some things, but what I have found is, regardless of the fact that much of the data that I am going to talk about today has been around for anywhere from several to 15 or even more years, there is still a vacuum of information both in the lay public as well as in the medical professional rounds and circles. And that it seems like every week in clinic I will have patients telling me the same thing, which is, my doctor told me I had to stop hormones. My doctor told me I had to stop hormones. I don't want to take hormones because they're bad for you. I don't want to take hormones because they're dangerous. Okay, but we just took your ovaries out at age 45. I know, but hormones are dangerous, so I don't want to take them. So those conversations that I have with patients keep coming up over and over, and I figured that now would be a good time to review kind of the state of the art and kind of where we are today in 2019. I wanted to briefly acknowledge a few things. I don't have any conflict of interest, and I don't have any off-label use. I also wanted to thank a member of our audience, Dr. William Patton, who is here. I was wondering if he would be here. Dr. Patton is one of my mentors, and he was kind enough to share some of the lectures that he's given on this topic over the years. So I wanted to just thank him for that. Appreciate that. So the lecture overview, today we're going to talk a little bit about menopause. We're going to review the menopausal transition. We're going to talk a little bit about the perimenopause and common symptoms, pathophysiology. And then we're going to dive into a discussion of menopausal hormone therapy. We'll go over a brief history and then an arc of the past and current recommendations in terms of the current evidence. So let's start and talk a little bit about the perimenopause. The perimenopause is a transitional time. Many times I'll have patients that will come into the office and say, I'm having this symptom or that symptom, whether it's bleeding or other symptoms, and when is the menopause going to be done? As if to say that as soon as they stop bleeding, all of their problems will be over. And what we've found is that, that certainly is not the case. In fact, many of the symptoms of menopause persist longer after the last menstrual period than they do beforehand. So the perimenopause is a transitional time. Here, let's just remind ourselves of a couple of mean or average statistics. You can see here that the menopause in North America, average age has rested steady at around age 51, but you can see that there's kind of a curve there, and that patients will go through menopause anywhere from the early 40s, which would be quite early, up until the late 50s. You can see there that this is preceded by changes in ovarian hormone production. In the 30s, patients will begin to have some reduced fertility. Many patients will not be able to get pregnant when they get into their early 40s, although you certainly can't count on that, as we've seen patients who come up with an unexpected pregnancy even when they thought they didn't need to take contraception. Cycle irregularities usually will begin in the later 40s in a patient who otherwise has normal ovarian function. And generally, we would consider this to be the onset of the perimenopause. So the perimenopause is really a transition period between normal ovarian function and ovarian failure. Typically that is a decline, but it is not a smooth and predictable decline. Most of the menstrual changes last for somewhere in the neighborhood of 4 to 5 years as far as bleeding changes. And they begin on average around age 46 to age 47. The consequences, or I should say the symptoms that patients have are consequences of what is happening in the ovaries. Remember, in the ovaries you have follicles. You're born with all of the follicles that eggs that you'll ever have, and then over the time period of really birth until you are completely through the menopausal transition, the egg number or the follicle number decreases. And so in the 30s and 40s, as the egg number decreases, you'll have some asymptomatic changes. You'll start with normal cycles, and then you'll get into some what we call decreased ovarian reserve, where patients have a difficult time getting pregnant. They may come in, I've had patients come in their late 30s and say, I don't know if anyone has ever seen this happen, but a patient, even a well-educated, I can remember even physicians coming in to me and saying, well, I've been on a birth control pill for the last 20 years, and now I'm 38, and I've finally established my career, so I've stopped the birth control pill, and I saved up all my follicles, so now I'm going to go ahead and try to have a family. And unfortunately, the surprise to them is that no matter what is going on, whether you're on birth control pills, whether you're pregnant, whether you are whatever other things that are happening in your life, the egg number, the follicle number in your ovaries is steadily declining. So generally in the 37, 38 range, patients have a difficult time a little bit getting pregnant. The symptomatic clinical perimenopause, as I said, starts generally around age 47, and it typically begins with not ovarian failure, but ovulation failure. Remember, ovulation, which is a monthly release of the egg, is really what times a normal monthly menstrual bleed. As ovulation begins to become less predictable and begins to fail in this time frame, patients will begin to have all manner of abnormal bleeding. Sometimes they'll come in with no period for several months. More often, they'll come in with multiple episodes of bleeding or bleeding that's quite prolonged. Dr. Patton once told me that he would like to start the Institute for Abnormal Bleeding, because if we started that institute, we would never lack for patients. There's always patients that have abnormal bleeding, even before this, for other reasons. And I've found that in my career as well. Estrogen deficiency symptoms will start a little bit later on, typically again in the later 40s, early 50s, patients will begin to have some of the symptoms of estrogen deficiency. And then ovarian failure, as I mentioned, on average age 51, will lead to complete loss of bleeding and the menopausal transition being complete. If you take a look at this, again, I lifted this from one of Dr. Patton's lectures, but I always remembered what he told me was that the perimenopausal transition is like the stock market in decline. You can see here that this is in general, the trend line goes down, but it is not a smooth transition. And so many patients will say, well, I think I'm kind of getting into the menopause, I've had a few less periods, and then suddenly they'll come back months later or maybe even the next year with heavy bleeding all the time, bleeding that lasts for multiple weeks, and then think, what's really going on here? Then we might get that under control, and they'll go on to seem like they're going through the menopausal transition. Maybe they'll have 6 to 8 months with no bleeding, and then things will start back up again. So this pattern is seen in most patients that's going to last over that perimenopausal transition for years. The progesterone deficiency is typically linked to the abnormal bleeding, but estrogen deficiency will be linked to other symptoms that patients come in to talk about. And let's talk about those a little bit. Estrogen deficiency, again, begins typically in the late 40s or early 50s, and it does vary from one patient to the other as to what the estrogen deficiency amounts are and how they will really affect each person. Hot flashes are probably the number one discussed symptom. Hot flashes typically will be something that women will come in and want some therapy for. Again, either in the late 40s or early 50s. Night sweats come up, and those are linked to hot flashes. Sometimes women will discuss vaginal symptoms, maybe difficulty with intercourse, vaginal burning, or discomfort, although typically those are later symptoms. Now we're calling those genitourinary symptoms of menopause. Emotional issues often come up as well, and many times women find or wonder how those are linked to the menopausal transition. And then again, bleeding irregularities are variable but generally decreased. So let's talk a little bit about hot flashes. What is a hot flash? So a sudden onset of heat sensation. As a male gynecologist, I have to be very careful. I've never had a hot flash, and I don't ever claim to say I know what you're going through or I can understand. So I've always tried to be as sympathetic as I can. But for many women, this is a big difficulty and something that will bring them in. Generally, they feel this most likely in the face, neck, and chest, lasting for about 2 to 4 minutes, typically with a frequency of 1 or 2 per day, up to 1 per hour. Women often will say that it's associated with anxiety, sometimes followed by chills. And the question is, what is the cause of a hot flash? Really, hot flashes are increased sensitivity of the hypothalamus. The hypothalamus has this thermoneutral regulatory zone, and all of us have experienced that when we have a fever. You have a fever, the hypothalamic set point goes up, and your body says, I'm supposed to be warmer. And so how do you get warmer? You have chills, you may have rigors, you want to take a hot shower or put a blanket around you. And then you take some Advil or Motrin and your fever goes down. Now your temperature is maybe 102, but your body says it's supposed to be back lower again. So what happens then? You start sweating and sweating. You wake up from sleep and you're drenched in sweat. This is the same mechanism that happens with a hot flash, although it's happening in a very more concentrated and more sensitive way. The normal body temperature rise of 0.4 degrees will trigger these physiologic mechanisms, but with an estrogen decrease, a smaller increase or decrease in the core temperature will set these off. So these will cause these sudden, only several minute hot flashes or chills, and it does require previous exposure to estrogen. That's why you don't see hot flashes in girls who are premenarchal. Hot flashes that come at night are called night sweats. Often they are more frequent at night. About 69% of them are associated with awakening, and they account for 27% of wakefulness during the night. With hot flashes, again, we'll talk more as we go on through the slides, but many patients will feel like these night sweats that come on are the most debilitating because it wakes them up from sleep, and many patients, both men and women, have difficulty with sleeping already, and you're so glad to be able to get to sleep. So if you wake up, then suddenly you're back into a situation where you can't get back to sleep. Vaginal atrophy, most of us are fairly familiar with that. There's a loss of estrogen. Decreased blood flow through the vascularity of the vaginal mucosa causes a loss of elasticity. Vaginal narrowing happens with this, and a feeling of dryness. I've just explained this to patients many times when the the vaginal tissue gets thin, then there's a feeling of dryness. Even if the vagina isn't necessarily dry, it feels that way. There's a lack of ability for it to stretch, so obviously intercourse can be difficult, and many women will have difficulty even with movement, exercise, and other things they'll see. They will come in and complain about discomfort in that area. And then emotional instability. Emotional instability, again, is a tricky subject because it's multifactorial. Patients will say as they get in through the perimenopausal transition, I just don't feel right. Maybe they have some irritability. They'll joke that their husband is angry at them all the time because of the way they're acting, and they are literally frustrated by this and concerned about it. It does seem to vary from week to week and month to month, but most authorities that have looked at this feel that emotional changes in the menopausal transition are primarily linked to sleep disturbances, which are, again, related to hot flashes and vasomotor symptoms. I think all of us would say that on a night when we've had very little sleep, our mood may be changed. We may be more irritable, less patient, and if that's happening night after night, you can imagine how that could lead to some emotional difficulties. Bleeding irregularities, again, we've already talked about a little bit. With ovulation failure, there's a loss of progesterone being produced, and that causes abnormal bleeding. And then over time, ovarian failure causes a loss of estrogen, which causes skipped months, and then finally amenorrhea. So the consequences of the menopause really could be divided up into two main categories. One would be short-term symptoms, although short-term is probably not the right word, because these can last for years. Flashes, sweats, atrophy, mood changes, and bleeding changes, as we've talked about. And then we also have other changes that are slower that you may not necessarily notice. Bone loss, cardiovascular disease, dementia, body composition, and skin changes. And these are long-term health changes that are happening during that and after the menopausal transition. Real quick review, I think most of us are familiar with this. Bone loss is a normal consequence of the loss of estrogen. It generally happens, the most rapid loss is in the year before to 2 years after the final menstrual period. There's an increased fracture risk, and of course we all know that there's excellent data demonstrating decreased fracture risks with estrogen therapy. As we'll talk about a little bit later, estrogen is no longer recommended as a first-line therapy for prevention of fractures because of concerns about risks. How about cardiovascular disease? Well, we know that there are changes, lipid changes that begin in the perimenopause are linked to estrogen loss. LDL increases by about 6% in the early postmenopause. There's not much change in HDL, but many studies think that there's a less protective effect of HDL after estrogen loss. So a question that has always come up is cardiovascular disease increased because of menopause or simply because of age? And we'll talk a little more about this as we go on, but because of the lack of benefit seen in the Women's Health Initiative and some other trials for both primary and secondary prevention, the uncertainty persists about whether or not estrogen is primarily responsible. One of the things you'll see as we move on here is conflicting data, and I'm going to try to show that to you in a way that helps to sort it out a little bit as we move forward. Dementia, I know we're going to have a lecture following this regarding dementia and Alzheimer's disease specifically, but again, this is an area where there is some uncertainty. Some epidemiologic evidence has linked hormone therapy over the years to a decrease in cognitive decline. However, other trials showed that there were no differences between hormone users and placebo users, and several studies have shown an increase in cognitive decline with women who were put on estrogen to try to prevent that. So there's still uncertainty about this consequence of menopause and hormone therapy. How about body composition? Most men and women will gain weight over the course of the years of their life. Men, of course, can't necessarily use menopause as a reason for weight gain. Sometimes we may call it menopause when we start to get a little bit more heavy around the middle. What is the cause of that? Is menopause really a cause of weight gain? Probably not, but several studies do seem to show that there is a change in body composition in terms of central adiposity when there is an estrogen loss. And that obviously can seem to a patient as if they're gaining weight. Skin changes. There can be skin changes. Again, this is another area where studies have kind of looked at this and not always come up with the same results. We do know that estrogen loss leads to an accelerated collagen loss, and decreased collagen is associated with wrinkling and aging of the skin. Whether or not hormone therapy will make a big change in that is somewhat uncertain. So now let's kind of switch gears. That's just as quick as I can go on an overview of sort of the groundwork for what's happening during the perimenopause. And let's talk a little bit about menopausal hormone therapy. Is it the fountain of youth, or is it a poison? We live in kind of a all or none world, right? If you look at reviews, almost everything is either 5 stars or 1 star, if you look at the Amazon reviews. So I thought that this is also seen with menopausal hormone therapy, that patients will, and physicians, will often feel either very pro or positive or just very negative. And I think, as with most things, the answer probably lies somewhere in the middle. This slide shows life expectancy over the 1900s. And you can see that's gone up significantly. If you take a look, really the area under the curve here is the menopausal time frame for women. And so it's really not until the last 100 or so years that this has become something that we really studied a lot, because before that, so many women on average didn't last too long into the menopause that it wasn't a big idea. So just going to a couple of quick fun clippings from the past. You can see here in 1920, owing to modern methods of living, not one woman in 1,000 approaches this perfectly natural change in her life without experiencing a train of very annoying and sometimes painful symptoms. These dreaded hot flashes, fainting spells, nervous troubles, and irregularities are symptoms that should have prompt attention. These 2 letters prove what a successful remedy Lydia E. Pinkham's vegetable compound is for women at this time of life. And then there's some letters that are pasted into this advertisement. Back in the 1930s, estrogen was extracted from mare's urine, and this kind of was really the beginning of looking at estrogen and how it could potentially be used. Erst, in the 1930s, was still extracting urine from pregnant women, but it was problematic in terms of supply, bad taste, or odor. Grant, a biochemist at that company, suggested in 1939 that possibly a water-soluble ester could be extracted from mare's urine, and that is how we got conjugated estrogen. Premarin, a conjugated equine estrogen, was approved in the early 1940s, both in Canada and the United States, to treat menopausal symptoms, and we were really off and running at that point. In 1966, this book by Robert Wilson called Feminine Forever was published, and that brought estrogen replacement to the attention of the public and increased its use dramatically. You can see here that this is the documented story of one of modern medicine's most revolutionary developments and breakthroughs, that the realization that menopause is a hormone deficiency, totally preventable, and now almost every woman, regardless of age, can safely live a full sex life for her entire life. It's interesting that it's written by a man. I'm not sure how much that correlates with the topic, although it probably had something to do with it. Again, a few other interesting, Here's an ad. I'm not sure when this is, probably from either the 50s or the 60s. It says, "The physician who puts a woman on Premarin when she is suffering in the menopause usually makes her pleasant to live with once again. It's no easy thing for a man to take the stings and barbs of business life and then to come home to the turmoil of a woman going through the change of life. If she is not on Premarin, that is. But have her begin estrogen replacement therapy with Premarin, and it makes all the difference in the world. She experiences relief of physical distress, and also that very real thing called a sense of well-being returns. She is a happy woman again, something for which husbands are grateful." Wow. Can you imagine this being published today? Premarin, or conjugated estrogens, a complete natural estrogen complex, is available in tablets and liquid, also in combination with meprobamate or methyltestosterone. Anyone know what meprobamate is? Yeah, that's like an anti-tranquilizer, basically, of barbiturate. So again, interesting times and how they've changed over the years. So as that, again, just a brief look into the history from the 30s up through the 1990s, we were really in a time frame where estrogen was considered to be the fountain of youth. The state-of-the-art in the 1990s was that hormone replacement was for relief of symptoms, but also because of a number of epidemiologic studies that had been going on during the 80s, it was also felt to be disease prevention, bone loss, and cardiovascular disease. These studies were observational, so it was uncertain. What did we know from those? These facts have been suggested that estrogen does have a role in prevention of coronary artery disease in women. Facts that say the incidence of coronary artery disease in women is 1/3 that of men before menopause, but then equalizes after. Coronary artery disease is the leading cause of death in menopausal women. Premature menopause increases MI risk by 2 to 3 times. Oophorectomies at a young age increases an MI risk by a dramatic 7 times. And oophorectomy at any age before 58 statistically decreases life expectancy. LDL cholesterol also increases after menopause. So these facts have been known for a number of years. In fact, if you take a look at the Nurses' Health Study, you will see here that causes of death compared to never users and current hormone therapy users showed statistically significant differences for all cause, coronary heart disease cause. You can see there a hazard ratio of 0.47. So that looks like the fountain of youth to me. Strokes was not statistically significant, and cancer also statistically significant decrease in women who were current users of hormone therapy. Again, this study from the 70s through the 90s. However, because these were observational studies, they were and are subject to significant bias, mainly the healthy patient bias, that women may choose estrogen who are women who are already healthier. Experimental trials, as we all know, are random assignments that will measure a dependent variable with random assignments of hormone. And of course, we know that these are not equal. So what happened in that time frame was a number of people. One of the most important initiators was the manufacturer of Premarin and Prempro came together to say, let's look at this really from a randomized experimental trial. So the Women's Health Initiative came along, and it was begun in the early 90s, enrolled over 160,000 women with an age range of 50 to 79, was 3 clinical trials and an observational trial, and it addressed questions about hormones, dietary modifications, calcium, and vitamin D. The hypothesis was that estrogen therapy would result in a decrease of coronary heart disease and osteoporosis-related fractures. Again, think about that in the context of today. The hypothesis at that time was if we put women on this, they will have less coronary heart disease. Didn't have anything to do at that point with symptoms. What it had to do with was prevention of chronic disease. The primary adverse outcome was a concern about breast cancer, and then other outcomes were also monitored: stroke, venous thromboembolism and its sequelae, endometrial cancer, colon cancer, fractures, and all-cause mortality. There were two groups and a placebo group. The first group was 5,310 women that had previously had a hysterectomy. They were given estrogen only compared to a placebo. And then women with an intact uterus, had a larger group, 8,500 patients compared to placebo, were given both estrogen and progesterone. And of course, as you probably know, in this trial, sponsored by Wyeth Erst, Prem-Pro was the medication that was used. So what happened? Pretty much everybody knows about 2001, 2002, just when I was finishing up my residency, we had a surprise. The trial was halted in July of 2002 because the trial met predetermined risk levels, preset risk levels for the risk of breast cancer, which we thought that it might cause, and also coronary heart disease, which we thought it was going to prevent, was getting worse, as well as strokes, venous thromboembolism, and others as well. Quick look at the results of the Women's Health Initiative for all comers was that heart attacks, strokes, breast cancer, venous thromboembolism were all increased over the study period. And this was big news. A typical news report would say, well, we found a landmark study was halted today when we found that estrogen increases the global risk of many different diseases. A 29% increase in coronary heart disease, a 22% increase in total cardiovascular disease, a 26% rise in invasive breast cancer, 41% increase in stroke, and 111% increase in venous thromboembolism. And these types of announcements were made throughout the media. Even though I was a brand new attending, I can remember right away that our phones were ringing off the hook with patients who were on hormone therapy and were terrified. How do I get off? How do I stop? Should I just stop cold turkey? Why did you give this to me? This is a poison. What are you trying to do to me, doctor? What can I do? And those of you who were practicing through that time, I'm sure remember the same thing. So really, hormone use plummeted in 2002. There was a sell-off. The oral use of menopausal hormone therapy in women over 40 was about 22% in 1999, 12% by 2004, and 4.7% by 2010. So that is a dramatic decrease. And I don't think Wyeth Erst was too happy with the results of the study as well. They had a lot of business changes, I believe. So, remember we talked about there was a second group, and that was the estrogen-only group. So the estrogen-only group went on until 2004, and then it was also stopped after 6.8 years. And what we found was some differences that I think most of us now believe were significantly overshadowed by what had come before. The risk of heart disease, the primary outcome, did not appear affected. Stroke risk was increased. Osteoporosis risk was decreased. That's something we knew. Breast cancer risk was decreased. That was not something that made the news in my memory. And you can see here for the estrogen-only group that there was a decreased risk of heart attacks, increased risk of strokes, decreased risk of breast cancer, increased risk of VTE, increased risk of colorectal cancer, and decreased risk of hip fractures. Now, not all of these were statistically significant, so I put this in to show that, and we'll go over it in a little bit more detail. But this result was not nearly as publicized as the previous. And you can see here that if we look at observational studies, in the first column, Women's Health Initiative estrogen only in the second column, estrogen and progesterone in the third column, that we see some significant differences. One, you can see breast cancer at the top. The estrogen-only arm showed a decreased risk, although look at the confidence interval, 1.01 was just outside the range of meeting statistical significance, whereas in the combined group, 1 to 1.59 barely met statistical significance to show an increased risk of breast cancer. And then again, coronary heart disease, you can see here that in observational studies was 0.61, whereas in the estrogen-only trial it was decreased, but not significantly. And in the estrogen and progesterone trial, it was increased and did meet statistical significance. So the consequences, by the time the second arm of the Women's Health Initiative was published, the reputation of estrogen as a poison was firmly established. The rates of use remained in free fall, and doctors stopped prescribing menopausal hormone therapy altogether. Many patients suffered from this, as you might remember, and a few doctors scratched their heads. Why was this? Inconsistencies came up. Why was so much observational data upended by these results? How could estrogen be a vital part of a woman's life through the premenopausal years and then suddenly become a poison? So these ideas were floated. What about age and timing of initiation? Maybe the progestin had something to do with it. Maybe the route of delivery, whether oral or transdermal, had something to do with that. What do we know about estrogen? Again, back to basic science, we know that it improves lipid profiles, it enhances endothelial function in younger women, it increases serum triglycerides, it does have some prothrombotic effects through the hepatic pathway. And then the natural history of coronary artery disease, I won't spend too much time on this, but you can see here that over the years, plaques and fatty plaques develop in the coronary arteries, which then form these plaques with a fibrous cap. And later on, these change with a necrotic core, and matrix metalloproteinases are deposited in the shoulders, which then weaken that, leading to plaque rupture. At what stage in this process would estrogen therapy or menopausal hormone therapy influence further progression? And does it matter when the therapy is begun or how long the therapy is continued? And these were really the questions that many physicians began to think about in the years following the publication of the first and second arm of the Women's Health Initiative. Again, let's look back at the Women's Health Initiative. The mean age of all comers in that was 63. I've been in practice for almost 18 years, and I have never had one patient that came to me over the age of 63 and said, "I'm here, doctor, because I've decided I want to have some hormone therapy for symptoms," as a first visit for that. That never happens. Many patients will come to see me in the late 40s and early 50s because of symptoms, and those are the patients that we would consider initiating hormone therapy for. But remember, Women's Health Initiative started with the idea that if we were to give hormone therapy to women in their 60s, that it would prevent chronic disease. So you can see that because of this, there was expectations that there were much higher rates of subclinical coronary artery disease and plaques that we felt now, looking back, maybe had a much higher risk of causing the abnormalities seen in the first, certainly the first publication of the first arm in 2002. So how might aging and its associated progressive atherosclerosis blunt or appear to blunt the protective effect of estrogen? We believe that now the inability to alter the endothelium after it's covered substantially by an atherosclerotic plaque probably has a lot to do with that. Also, if you put women through an entire age range on estrogen, the bad outcomes of the women who are in this older part of the study will definitely blunt the possibility of seeing any positive effects in the women who are younger. How could estrogen be harmful in women who already have atherosclerosis? And we talked a little bit about this. Plaque instability results from thinning of the fibrous cap. MMPs accumulate in the shoulder regions, and we know that menopausal hormone therapy increases the expression of MMPs in postmenopausal women with coronary artery disease. So these facts we know could probably lead to the fact that a mature, less stable plaque is formed early on, and estrogen may make that more likely to rupture. So because of this, again, many, many people began to think, what would happen if we were to look at a subgroup of women who were exposed to estrogen earlier? And in fact, this has led to much of what has happened over the last 15 years with the Women's Health Initiative and other studies looking at subgroups. And we have found that in the subgroup analysis, the coronary heart disease hazard ratio in women who are taking hormone therapy who are less than 10 years menopause is actually significantly different from the women who are in the 10 to 20 or over 20 years. In fact, the probably best look at this was a 2015 meta-analysis that culminated data from 19 trials, including the Women's Health Initiative, and it included 40,000 postmenopausal women and a subgroup of women who started menopausal hormone therapy less than 10 years after menopause showed lower risks of coronary heart disease and mortality compared to placebo. This was probably our one chance, this meta-analysis, to actually have a study published that showed that estrogen helped to prevent coronary heart disease. Because it actually did, but the problem was there was one flawed study, and that was removed. So even though the trend showed that in this subgroup of women, coronary heart disease was decreased, it was no longer statistically significant, and you know how that works. When there's not statistical significance, then it's no longer put out as something that would be a practice change. But at least in this group, we would say there was no excess risk of coronary heart disease seen in this subgroup. So because of this meta-analysis and other studies that have led up to this, the state of the art now from 1990 to 2016 is that hormone therapy is excellent for relief of symptoms, hot flashes, sweats, mood changes, vaginal changes. But as far as disease prevention goes, we haven't been able to say that even in this subgroup, estrogen or estrogen and progesterone therapy prevent coronary heart disease, even though we do know it prevents bone loss, prevents fractures. So let's regroup. Hormone therapy, does it prevent symptoms? Yes. Prevent bone loss? Yes. Prevents coronary heart disease? Have to say no based on the cumulative evidence. Causes excess coronary heart disease? Depends, right? It depends on what age group you would initiate. Has other benefits? Yes. Other risks? Yes. Should it still be used? Well, let's take a look. Let's look at the risk and benefit. And let's look at it now differently through what we now know or call the timing hypothesis. So if we take a group of women, and this, if you remember anything else about this, I'd like you to kind of focus in on this. I don't know what everybody out here in the audience does in terms of their practice, but I do know that these are the places where I see still so many patients saying that they're not going to take hormones because either they're scared of it or their physician told them they shouldn't because it was bad for them. So let's take a look at this timing hypothesis. Let's take women who are within 10 years of menopause, age 50 to 59, and we'll look at 1,000 for every 1,000 women for 5 years of use. We'll look at additional cases, risk, and fewer cases, benefit, for each one of these things. So this is something that I talk to my patients about, and I'll show them these numbers. So if you look at women who have a uterus who go on estrogen and progesterone, let's look at these. Remember, this is for 1,000 women, risks and benefits. Coronary heart disease and MI, 2.5 more cases. Stroke, 2.5 additional cases. Venous thromboembolism or pulmonary embolism, 3 additional cases. Breast cancer, 3 additional cases. Colorectal cancer, 0.5 fewer cases. Hip fractures, 1.5 fewer cases. And then all-cause mortality, another interesting stat that I don't have a lot of time to talk about, but looks at mortality for any cause, including the ones listed above, 5 fewer events in this group. Now, what about women who have had their uterus removed? Many patients who have their uterus removed then either have their ovaries preserved and they'll go through a natural menopause, or their ovaries are removed, they'll go through a surgical menopause and then need to decide for themselves whether or not they're going to take estrogen only. So in this group of women, what do those numbers look like? Again, these are not all in the statistically significant range, but they're in the trend range. So for coronary heart disease and MI, 5.5 fewer cases. Stroke, 0.5 fewer cases. Venous thromboembolism, 1.5 additional case. Breast cancer, 2.5 fewer cases. Colorectal, 0.5 fewer cases. Hip fractures, this again doesn't make a lot of sense, but 1.5 additional cases. And all-cause mortality, 5.5 fewer events. So this slide, I think, really summarizes what I would consider to be the state of the art in terms of, I'm almost done and I'll get to questions in just a bit. In terms of state of the art, in terms of what we would consider to be recommendations from all societies today for women in this 10 years following menopause. You can find this graph. This is a common graph. It's on the internet, and this one is one that I've printed out to give to my patients, and it really summarizes in graphical form what I just showed in numeric form. And you can see there that the tan bars are estrogen plus progesterone, and the blue bars are estrogen alone. So the highlights, again, just to kind of go over, overall risks for hormone therapy in younger postmenopausal women are considerably lower than those for older women at initiation. Estrogen alone treatment in appropriate patients has a lower overall risk compared to combined therapy. We didn't talk much about it, but transdermal estrogen as the mechanism for estrogen to get in is probably considered to be the most physiologic mechanism. It avoids the gastric and hepatic first pass, which we believe has most of the prothrombotic risks. And nothing is better at treating menopausal symptoms than estrogen. So again, we can still see, look at the decline of menopausal hormone therapy over the last, this goes up to 2010. I don't have any later statistics to that. And the one question that comes up is the economic impact. The authors of the Women's Health Initiative did do a study looking at the economic return. This was published in 2014, that showed 4.3 million fewer users, 126,000 fewer cases of breast cancer, 76,000 fewer cases of coronary heart disease, 263,000 more fractures, and 35 billion in savings. But what they didn't take into account was declining use of estrogen only in women who had a hysterectomy. So that study was looked at in 2013, called the Mortality Toll of Estrogen Avoidance. And that showed that in estrogen therapy in younger postmenopausal women, because of the decline in use over 10 years from 2002 to 2012, anywhere from 18,000 to 91,000 women died prematurely because of estrogen avoidance. So this is a quote from this paper. It says, research findings are often nuanced and need to be reported accordingly in both the peer-reviewed literature and the popular press. And it's the responsibility of biomedical researchers to report findings in a way that the media and the general public can clearly understand. I think this is seen very commonly because of the way the media reports on studies. And you can see from what I've laid out that because of the reports of Women's Health Initiative back in 2002, we really ended up with long-term consequences that are difficult to reverse even up to this day. Real quick, a word about risk. Sometimes I will put this up and show patients, when patients are facing a choice of taking a medication, it is a brand new big decision for them. A brand new big decision is in and of itself a bias. Suddenly we assign much more importance to a brand new big decision than we do to everyday things in our life. One of my common things when I'm counseling a patient about surgery, I'll say, you have this risk, that risk, the other risk. Generally, we think those are less than 1%. And patients may be nervous about it. I don't know if it's worth doing this or worth doing that. Same thing with hormone therapy. I don't want to do it even if there's even the slightest risk. And I'll say, how did you get here today? What are you talking about? Well, how did you come to my office? I just drove here. Oh, you drove your car here? Were you concerned when you got in your car that you were going to get into a car accident on the way here? And again, people don't think about typical risks because it's something that in our lives we just take for granted because we're used to it. And so juxtaposing the risks that are very small with a therapy that may be very beneficial can be helpful in women, I think, or in anyone with medications as we look at that in comparison to other risks in our lives. So again, recommendations from societies here is that initiation of menopausal hormone therapy is safe in the first 10 years after menopause. Endocrine Society actually has a risk calculator that I don't use very often, but that can be used. Progestin therapy should be used for women with an intact uterus. Women who only have genitourinary or vaginal symptoms may be best treated with topical vaginal estrogen. And again, the party line is that menopausal hormone therapy is currently indicated for symptom relief, not chronic disease prevention. I'll try to wrap up here. I know I'm going over just a bit, but I wanted to just go over one more point, which is discontinuation, because this comes up a lot. Patients will say, I'm 60 and my doctor said I had to stop estrogen. And they'll come in to see me and they're feeling horrible. Maybe they have a recurrence of all of their symptoms. Studies show that a significant number of women, my recollection is probably up to 40% of women, will still have menopausal symptoms into the 60s. And a smaller number, but not zero, will still have menopausal symptoms into the 70s. So the question is, what to do with patients who are beyond 10 years? Should they consider discontinuation or should they consider continuing? Again, the party line is that we should consider discontinuation because of the risks. But if I would like to sort of editorialize anything, it's that the studies seem to show that initiation early has benefits even beyond the 10 years that we don't probably have great statistics on. What would happen for patients who continue if they started early? Those statistics are still a little fuzzy. Both ACOG and the North American Menopause Society agree that discontinuation should not be based solely on a patient's age. So for women who come in and they have ongoing symptoms, typically we're going to talk about their risk profile, and it's always going to be individualized. Each patient is going to have some reason why they maybe shouldn't continue therapy based on their health risks. The more cardiovascular risks they have, the more concern there might be. So these discussions should be individualized, but I guess what I would like to emphasize is shared decision making. What I would rather have a patient say is, I talked it over with my doctor, we reviewed the pros and cons, I decided the risk was a little high, so I stopped therapy. Yeah, I'm still having some hot flashes. We can look at some other maybe non-medication therapies, but I've decided to stop. Or they might say, after we discussed it, I decided that I'd rather have that therapy. I like the way I feel on it. I'm willing to take a small, maybe unknown risk or a small amount of risk and continue on with that. Last slide here is just some personal thoughts. Consider estrogen therapy for all symptomatic patients and discuss risks and benefits in light of their overall health. This is off-label, but I will say that many patients who have a uterus, we consider putting them on a progesterone-releasing IUD for patients who are appropriate into the menopause, who would like to have the benefits of the estrogen-only arm of the data that I showed you and not use the progestin. And this can protect the endometrium from overgrowth. The other thing is to consider transdermal estrogen, consider continuation over age 60 rather than initiation over age 60. And again, always put the patient's personal values over one's own, as their acceptance of risk versus benefit may be different from ours. So again, I'm sorry I went a couple of minutes over. I will be happy to take any questions. A lot of data there. Yes, sir.
What about the large group of women who had breast cancer in their 50s and now taking estrogen blockers for the rest of their life?
That's an excellent question. The question is, what about women who have had breast cancer in their 50s? So that, again, that probably could do a whole lecture on that. There's, again, the theme of conflicting data. Breast cancer is not a homogeneous disease. It's a heterogeneous disease. And as you know, many breast cancers have various growth receptors, growth factors. I think overall the answer is that it's very difficult to get any group of oncologists to agree to give women estrogen or estrogen progesterone who have had breast cancer. Because even if we might believe that it's not a de novo cause of breast cancer, it certainly is known to be a growth factor. So in those patients, we often will do alternative therapies, whether that typically non-hormonal based therapies. I saw some other hands. Dan?
As I recall, your slide would be more accurate if you said CEE/MPA instead of estrogen and progesterone, and the other one would say CEE.
That's correct.
So those are very different compounds. How would you deal with the data that showed that women who stopped permanent after WHI had increased incidence of myocardial infarction 2 or 3 years after they stopped?
After they stopped, they had an increase in myocardial infarction. I would deal with that in the same way that I would deal with the rest of the data that does show that, again, the question is stopping hormone therapy may have an increased risk to patients. And again, that's often not emphasized. So I appreciate you bringing that up. And you're correct that the data that I am presenting, I'm putting menopausal hormone therapy and estrogen therapy, but you're correct, it's MPA and CEE.
I may have missed comments about bioidentical hormone replacement.
You didn't miss them. I actually cut that part out of the lecture. That'd be another half an hour. But bioidentical hormone therapy is a broad topic that I'll just say many societies frown upon it, but it's for various reasons. It can be used safely, and it has a lot of the same implications for what we already talked about. Yes, sir.
Could you comment on ovarian preservation for subsequent follicular development, and also ovarian transplant as a therapy for what the status of that would be?
Probably don't have a lot of comment on that other than just to say that typically ovarian preservation is something that we look at the time of hysterectomy in every patient individually. There's been a number of studies that have looked at ovarian preservation at the time of hysterectomy, again with various findings. Bill Parker from UCLA's study showed that there was a ongoing benefit to keeping the ovaries well into the 60s. So in many patients, we do consider keeping ovaries at the time of hysterectomy. Some of the data that wasn't available when he published that study was regarding fallopian tubes. We know that the fallopian tubes have now been implicated in the genesis of many epithelial ovarian cancers. So the ability to take out the fallopian tubes at the time of hysterectomy, or even at the time of sterilization, has led to a significant even decrease further in the risk of ovarian cancer, which may lead to the ability for patients to go through a natural menopause rather than have their ovaries removed because of fear of cancer. As far as ovarian transplant, I probably don't have a lot of good information on that right now, but I do appreciate the question. I think there's another one up
One more
up top.
question in the back row.
Does endometrial ablation shift one into the uterine preservation or move them into the ovarian-only categories?
You mean if you do an
Like a
endometrial?
Novasure where the, myometrium's still preserved, but the endometrium's all been ablated.
So if you do an endometrial ablation, would that, restate your question, if I do that, what's the question?
In some of your slides, you were separating, what type of therapy.
Hormone therapy?
Yes.
Okay.
Whether or not the uterus was preserved. And I said, so what happens if somebody's had a partial, like a uterine ablation,
So,
endometrial ablation?
correct, that's a good question. If a patient has had an endometrial ablation and then requests or decides on hormone therapy, we would put that patient on both estrogen and progesterone. Almost all of the methods, really all of the methods for endometrial ablation are certainly not guaranteed at all to ablate 100% of the endometrium. So we would still consider that endometrium to be at risk. And I think I'm probably out of time, Dan.
Thank you very
Sorry,
much,
thank you so
Kevin,
much.
for that great, very important presentation.